We described the common mechanisms of bacterial resistance to antibiotics and explained the mechanism of action and spectrum of activity of glycopeptide, lipopeptide, and beta-lactam antibiotics. And given the patient with suspected bacteremia, including sepsis and septic shock, we recommended appropriate empiric therapy, and we changed empiric therapy to pathogen-directed therapy based on blood culture and susceptibility results. Now, let's select total duration of therapy for bacteremia based on causative organism and patient characteristics. First, let's consider the role of follow-up blood culture. Of course, the initial blood culture is used to diagnose bacteremia. However, occasionally, based on the causative pathogen, we need to document clearance of the organism from the blood. So therefore, there is a need for follow-up blood culture to make sure that there is a negative blood culture based on the treatment. Specifically for Staphylococcus aureus, Staphylococcus lugdunensis, which is a coag-negative staph, and specifically for patients who have deep-seated infections and patients who have prosthetic devices in their body, it is important to document clearance with the follow-up blood culture to make sure that there has been sufficient source control and there is low risk of persistence or recurrence. In addition, there is a need for follow-up blood culture if there is a lack of clinical improvement or if the patient deteriorates despite treatment. That could mean, essentially persistent bacteremia or lack of source control. And there is an algorithm that you can take a look at in order to understand the process more. And essentially, this goes over what I simply summarized here. And you might wonder why not just get follow-up blood culture for everyone to document clearance. And the reason is that unnecessary blood culture is associated with increases in hospital length of stay, antibiotic use, and other lab testings, and they may lead to anemia, patient discomfort, at adverse events. So therefore, we want to minimize or eliminate unnecessary follow-up blood cultures. So in general, for most gram-negative bacteremia where the patient is improving, people clinically typically do not get a follow-up blood culture to document clearance. Now let's talk about Staphylococcus aureus bacteremia, because not only the rate of mortality is typically 20 to 25% in patients with Staph aureus bacteremia, but also Staph aureus is notorious for having recurrence or persistence in patients. So it is recommended to repeat blood cultures every 1 or 2 days until we have a documentation of a negative blood culture. And in fact, for Staph aureus bacteremia, the very first negative culture marks the first day of treatment. So we actually do not count any days of antibiotics prior to that first negative culture. So if we say, this patient needs to get, this many days of treatment, day 1 is starting on the day that we have a negative culture. Now, it is important to classify bacteremia based on complications. So uncomplicated Staphylococcus aureus bacteremia, the recommendation for treatment is at least 2 weeks of either vancomycin or daptomycin. These are drugs of choice for Staphylococcus aureus bacteremia, specifically for MRSA. So this is for MRSA, vancomycin and daptomycin. For MSSA, we should be using beta-lactams active against MSSA. The reason these are listed here because these recommendations are coming from IDSA guidelines for MRSA specifically, and for duration of treatment we extrapolate these recommendations to MSSA bacteremia as well. So for MSSA, just ignore these agents, but the important thing is the duration of treatment. So we want at least 2 weeks of treatment for uncomplicated Staph aureus bacteremia, whether it's MSSA or MRSA. And the way we define uncomplicated is that essentially we want to exclude these 5 things. So we want to make sure that the patient does not have endocarditis, and the patient does not have implanted prosthesis, and we want to make sure that there is a follow-up blood culture performed on specimens obtained 2 to 4 days after the initial culture positive that is negative. In other words, if on day, the initial blood culture is positive and then 5 days later is still positive, and on day 6 the blood culture is negative, then it's considered complicated. So you want to get your first negative culture within 2 to 4 days of the initial culture. The fourth category is defervescence within 72 hours of initiating effective therapy. Defervescence essentially means resolution of fever. And the last one is no evidence of metastatic sites of infection. In other words, making sure that the bacteria, Staph aureus, from the blood has not gone to other sites in the body and caused other secondary infections. Otherwise, if the patient doesn't meet the criteria for uncomplicated bacteremia, then the patient has complicated bacteremia. And for complicated Staph aureus bacteremia, they need at least 4 weeks of treatment, depending on the extent of infection. So how do we decide 4 weeks, 5 weeks, or 6 weeks? So essentially, as the patient approaches 4 weeks, it's based on clinical judgment to see how well the patient is improving. And then if the patient is not improving, longer duration of therapy may be required for the patient. Now, these are specifically for Staphylococcus aureus bacteremia, not for other types of bacteremia. For gram-negative bacteremia, because these are less likely to persist, the duration of treatment tends to be shorter. In general, a total of 7 days of appropriate antibiotic therapy for patients with uncomplicated gram-negative bacteremia who have achieved source control, are afebrile for at least 48 hours, and are hemodynamically stable, especially patients with a urinary source of bacteremia caused by Enterobacterales. Otherwise, the patient may need 14 days of treatment, especially if it's a non-fermenting gram-negative organism such as Pseudomonas or Acinetobacter. And essentially, complication is the definition of complication is similar to what we have for Staphylococcus aureus. So if someone has endocarditis, deep-seated infections, or if they have hardware, essentially they will be considered complicated. The only thing that's not done for gram-negative is that we don't typically get a follow-up culture to document clearance. Although if you do, it would be a good practice, but it's not routinely done. So to summarize, when it comes to duration of therapy, so you consider, for gram-positive, MSSA or MRSA, if it's uncomplicated, you do at least 2 weeks. And, again, use clinical judgment. If the patient is not improving at 2 weeks, you, of course, want to extend the duration of therapy. And for Staph aureus specifically, the 2 weeks starts from the first negative culture. And if it's complicated, you do at least 4 weeks from the negative culture. For gram-negative organism, if it's due to wild type Enterobacterales, wild type meaning, it's not developing resistance to antibiotics, 7 days in uncomplicated bacteremia. Otherwise, if the patient has complicated or if it has resistant Enterobacterales, you do 14 days. And then for lactose non-fermenters, whether it's complicated or uncomplicated, we want to do 14 days. And you might ask, what if you have bacteremia due to other causes? So perhaps Enterococcus or Streptococci. Those are less common, and there is less evidence for specific recommendation for duration of therapy. So we will not discuss those in this class. This concludes this presentation.